Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 280 of our pharmacotherapy series, which majors in essential hypertension. The first question reads, CRP is a 68-year-old man with hypertension and a history of ischemic stroke 1 year ago. 2 months ago, his BP value was 164 systolic, 94 diastolic. It was 162 systolic, 98 diastolic when repeated, with a heart rate of 62 beats per minute while on sustained release diltiazem 240 mg daily. He was started on benazepril with hydrochlorothiazide 10/12.5 mg daily 2 months ago. His BP today is 142 systolic, 82 diastolic. It was 144 systolic, 82 diastolic when repeated. All his laboratory values are normal except his serum creatinine, which is 1.9 mg per deciliter. CRP has implemented lifestyle modification to the best of his ability. His physician is wondering if aliskiren be added to his drug regimen, considering he is also on ACE inhibitor. How is aliskiren different from an ACE inhibitor or angiotensin II receptor blocker? This is different from the decreased production of angiotensin II with ACE inhibitors and the blocked angiotensin II receptor effects with angiotensin II receptor blockers. However, BP-lowering effects are similar to those with ACE inhibitors and angiotensin II receptor blockers. Aliskiren has a 24-hour half-life and, similar to most ACE inhibitors and angiotensin II receptor blockers, is dosed once daily. Next we will discuss direct renin inhibitors. Aliskiren is a direct renin inhibitor. It inhibits the first step of the renin-angiotensin-aldosterone system, which results in reduced plasma renin activity and BP lowering. Some similarities and some differences exist among the side effects associated with aliskiren when compared with ACE inhibitors and angiotensin II receptor blockers. Aliskiren should not be used in pregnancy because of the known teratogenic effects from blocking the renin-angiotensin-aldosterone system. Increases in serum creatinine and serum potassium have been associated with aliskiren. These are similar to ACE inhibitor and angiotensin II receptor blocker therapy and are mediated by the inhibition of angiotensin II vasoconstrictive effects on the efferent arterioles of the kidney and blocking of aldosterone. Monitoring of serum creatinine and serum potassium should be done in patients treated with aliskiren, particularly in those treated with the combination of aliskiren and an ACE inhibitor, angiotensin II receptor blocker, potassium-sparing diuretic, or aldosterone antagonist. Angioedema has also been reported in patients treated with aliskiren. The next question reads, what is the role of aliskiren in treating CRP's hypertension? The exact role of aliskiren in treatment of hypertension is unclear. It is approved as monotherapy or in combination therapy. The BP reductions with aliskiren as monotherapy are similar to those seen with an ACE inhibitor, angiotensin II receptor blocker, or calcium channel blocker, specifically amlodipine. Aliskiren provides additive BP lowering when used in combination with hydrochlorothiazide, ACE inhibitor, angiotensin II receptor blocker, and calcium channel blocker. Its efficacy in combination with maximal doses of ACE inhibitor is unknown, however. Aliskiren is an alternative antihypertensive agent at this time because of unknown long-term effects on cardiovascular events. The next question reads, Tom is a 43-year-old man. He is a truck driver with a 5-year history of hypertension. He does not have hypertension-associated complications. Secondary causes have been ruled out. His regimen is losartan with hydrochlorothiazide 100/25 mg daily and sustained-release diltiazem 240 mg daily. Other antihypertensive drugs have failed because of various side effects. Captopril and lisinopril caused a dry cough. Atenolol and carvedilol caused fatigue. Nifedipine and amlodipine caused edema. Terazosin caused orthostasis. Tom has been adherent with his present medications and lifestyle modification, but has been unable to quit smoking. His clinic values have been similar and averaged 150 systolic 95 diastolic for the past 3 months. Clonidine 0.1 mg twice daily is added to his regimen. What problems might occur if TOM is not adherent with clonidine therapy? Alpha-2 agonists are most effective when used with a diuretic because they all can cause fluid retention. Ideally, they should be used with agents that have different mechanisms of action and with agents that do not affect other central adrenergic receptors. Clonidine can cause rebound hypertension when abruptly stopped. TOM's occupation may place him at risk for this complication if he misses doses because of unusual work hours or prolonged travel. The next question reads, how should TOM's clonidine dose be titrated? Clonidine should be started at a low dosage and gradually increased to achieve optimal BP lowering with minimal side effects. The immediate release tablet is started as 0.1 mg twice daily, with 0.1 or 0.2 mg per day increases every 2 to 4 weeks until his BP goal is achieved or side effects appear. Clonidine is also available as an extended-release tablet and as a transdermal patch. The patch formulation releases drug at a controlled rate for 7 days and may have fewer side effects than the oral dosage form. The onset of initial BP effect may be delayed for 2 to 3 days after application, thus rebound hypertension might occur when oral clonidine is switched to transdermal. To prevent this, an oral dose should be taken on the first day that the transdermal patch is used. Anticholinergic side effects, such as sedation and dry mouth, are the most frequent and bothersome side effects of clonidine. These are especially problematic in elderly patients. The next question reads, after several months, TOM's BP is 148 systolic 84 diastolic with clonidine 0.2 mg twice daily. However, he is now experiencing daytime somnolence and dry mouth. What other alpha-2 agonists are available? Let's begin with methyldopa. Methyldopa has been extensively evaluated and is considered safe in pregnancy. Therefore, it is recommended as a first-line agent when hypertension is first diagnosed during pregnancy. Beyond that, little role exists for methyldopa in the management of hypertension. The usual initial dose is 250 mg administered twice daily up to 2000 mg per day. Methyldopa causes side effects similar to those associated with clonidine, including sedation, lethargy, postural hypotension, dizziness, dry mouth, headache, and rebound hypertension. These may decrease with continued use. Other significant side effects include hemolytic anemia and hepatitis. Although these are both rare, they necessitate discontinuing the medication. The others include guanfacine and guanabans, which have a high incidence of side effects. These agents can cause dry mouth, sedation, dizziness, orthostatic hypotension, insomnia, constipation, and impotence. Guanfacine has a long half-life and may have less rebound hypertension than other alpha-2 agonists. The adverse effects of other alpha-2 agonists, methyldopa, guanfacine, and guanabans, are nearly identical to those of clonidine. In general, patients who do not tolerate one alpha-2 agonist will not tolerate the others. An antihypertensive agent from a different class, aldosterone antagonist, aliskerin, risapine, or an arterial vasodilator, should be chosen for TOM. The next question reads, would risapine be a reasonable option for TOM? Risapine is one of the oldest antihypertensive agents currently available. It is extremely effective in lowering BP when added to a thiazide diuretic. Risapine is inexpensive and is dosed once daily. Several of the landmark trials that demonstrated reduced morbidity and mortality with BP lowering in hypertension used risapine. The SHEP trial used risapine as a second-step agent added to chlorthalidone in patients who could not take atenolol. Low-dose risapine, that is 0.05 to 0.1 mg once daily, is effective at lowering BP and has significantly fewer side effects compared with high doses. Risapine can cause nasal stuffiness in many patients. Gastrointestinal ulcerations have been reported, but they are associated with either parenteral administration or very large doses. TOM is a candidate for low-dose risapine. He is already taking a thiazide diuretic, which should always be used with risapine, and his therapeutic options are limited. Of all the agents remaining for TOM, other than aliskerin, risapine has the most favorable side effect profile. Many clinicians avoid risapine because of the myth that it can cause depression. This fear was generated from case reports in the 1950s when high doses 0.5 to 1.0 mg per day were used. Many of the patients described in these cases would not meet modern criteria for depression, rather, they would be considered oversedated. When risapine is limited to a maximum of 0.25 mg daily, depression is no more frequent than with other antihypertensive agents. The next question reads, CCM is a 56-year-old woman with a history of hypertension and severe chronic kidney disease, that is an estimated GFR of 14 ml per minute per 1.73 meters squared. Her antihypertensive regimen consists of torsemide 40 mg daily, amlodipine with olmesartan 10/40 mg daily, and metoprolol succinate 200 mg daily. She started hydralazine 25 mg 3 times daily 4 weeks ago when her BPs were 148 systolic 92 diastolic and 146 systolic 90 diastolic. She has been very compliant, and her BP is now 146 diastolic 88 diastolic with a heart rate of 82 beats per minute. Her lung fields are clear, with 1+ bilateral pitting edema. Serum electrolytes are within normal limits. Why was hydralazine used in CCM? Hydralazine causes direct relaxation of arteriolar smooth muscle. Arterial vasodilators are infrequently used, except for patients with severe chronic kidney disease. In this population, hypertension is difficult to control and often requires 4 or 5 agents. Severe chronic kidney disease results in increased renin release and increased fluid retention. Potent vasodilation, in combination with diuresis, is often effective in lowering BP under these conditions. This vasodilation, however, stimulates the sympathetic nervous system and results in a reflex tachycardia, increased plasma renin activity, and fluid retention. Thus, the hypotensive effects of direct arterial vasodilators can quickly diminish with time when used as monotherapy. To prevent this, arterial vasodilators need to be used in combination with agent that can slow down heart rate, e.g., beta blocker or non-dihydropyridine calcium channel blocker, to counteract reflex tachycardia, as well as a diuretic, often a loop diuretic if used in severe chronic kidney disease, to minimize fluid retention. The next question reads, after 18 months, CCM's hydralazine dose is 50 mg 3 times daily, and her BP is at goal. She now complains of joint pain in both her right and left hands, which extends to the wrists, and generalized weakness with frequent fevers. Laboratory findings for CCM showed a positive anti-nuclear antibodies test diffuse, a white blood cell count of 3,500 per microliter, and an erythrocyte sedimentation rate of 45 mm per hour, and she is diagnosed with drug-induced lupus, abbreviated as DIL. How should this be managed? CCM's symptoms are consistent with drug-induced lupus. Hydralazine is one of the most common agents reported to cause drug-induced lupus. Musculoskeletal pains are the most frequent symptoms, but systemic symptoms and rash may also occur. Hydralazine doses as low as 100 mg per day can cause drug-induced lupus, and the risk significantly increases when greater than 200 mg per day is used. Hydralazine should be discontinued. Symptoms should subside within days or weeks, and complete resolution can be expected. The next question reads, what alternatives to hydralazine are available for CCM? CCM's BP responded to hydralazine, so she would likely benefit from another arterial vasodilator. Minoxidil, a potent arterial vasodilator, is similar to hydralazine with regard to reflex tachycardia, increased cardiac output, increased plasma renin activity, and fluid retention. Therefore, concomitant beta blocker and diuretic therapy is still needed. Minoxidil should be reserved for patients such as CCM who have severe chronic kidney disease or possibly for resistant hypertension. The last question reads, how should CCM be counseled if minoxidil is started? Hypertrichosis is a common adverse effect of oral minoxidil, occurring in 80% to 100% of patients. The hair growth is not associated with an endocrine abnormality and begins within the first few weeks. It commonly occurs on the temples, between the eyebrows, on the cheeks, and on the pinna of the ear. Hair growth can extend to the back of the legs, arms, and scalp with continued use. Some patients, especially women, find the hypertrichosis so intolerable that they stop treatment. Topical minoxidil is an approved therapy for male pattern baldness, but topical administration does not provide BP-lowering effects. Fluid retention with minoxidil is common, presenting as edema and weight gain. If adequate diuresis is not maintained during minoxidil therapy, left ventricular dysfunction may be precipitated or worsened. This also occurs with hydralazine. The compensatory reflex tachycardia with minoxidil may also precipitate angina in patients who have, or are at risk for, coronary artery disease. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 281.